That was an excellent session. So much importance on DE&I. I love it. Our next panel is going to be moderated for the first time by Michael Devlin, who is a strategic board member and advisor to the foundation. He's also kind of my partner in cause in all of this. So Michael, please join me on stage. He will be moderating a panel of clinicians and patients who will be talking about managing NMOSD and MOGAD symptoms.
Thanks, Samira. And I'd like to invite up on stage Ms. Botero, Dr. Jiang, Mr. Martinez, and Ms. Dr. Syan? I was guessing how to pronounce that.
You nailed it.
Syan?
Syan.
Syan, okay. There's Andre. And are we missing Maria? Jill? Are we missing Maria? Okay. Right, so before we get started, I'd like to have each of you introduce yourselves. You're not neurologists, you're neuro-ophthalmologists, but you all have diverse backgrounds. So please tell us a little bit about yourselves and what you do.
Hello, everybody. My name is Andres Martinez. I am a physical therapist with the University of Miami. I am a neurologically specialty physical therapist. I mainly work with individuals in the outpatient basis with a wide array of neurological conditions. I also work with the ALS multidisciplinary clinic. So in general, my work is really based on finding ways to problem solve with those who have mobility challenges that are chronic as a result of neurological conditions.
Good afternoon. I'm Raveen Syan. I am a urologist, but I also subspecialize in neurourology. So I help people with complex neurologic conditions, including the ones we're all here for, as well as many others, focusing on things like urinary issues, erectile dysfunction, troubles with urination, female sexual dysfunction as well. So that's what I specialize in.
Hi, good afternoon. My name is Jiang. I'm a neuro-ophthalmologist. Basically, we are the doctors who diagnose, we are the doctors who diagnose MOG or NMO, the first person to diagnose them, because those patients usually present first symptom as vision loss, optic neuritis. And we also monitor these patients because our test, there is a special test called optic coherent tomography. We can measure the thickness of the retinal nerve fiber layer and also the ganglion cell layer. And these two markers are considered as another marker to monitor the disease progression and the therapeutic efficacy of these patients, including NMS-MOG and NMSOSD and MOG-AD patients.
So the topic and focus of this panel is managing your NMOSD or MOGAD beyond relapse prevention. So for the patients that are fortunate enough to be properly diagnosed and they found a therapy that effectively prevents relapses, they have to get on with their lives, but they're often living with many other symptoms. The sources of those symptoms can be manyfold. For example, after your first attack or your subsequent relapses, you may be living with mobility challenges, vision challenges, other problems directly related to the relapse. You also may be living with side effects from the medications you're on, and you may also be living with other comorbidities. Many NMOSD and MOGAD patients, or at least NMOSD patients, I think you all know, have a high incidence of other conditions such as lupus or Sjogren's syndrome. So I'd like to ask each of you, I know you cover a broader range of disease states, but for patients with demyelinating conditions like NMOSD or MOGAD, what do you typically see as symptoms in your area of expertise?
In my case, I acknowledge that these patients might be dealing with a mixed bag of symptoms. I would say in terms of common complaints, there's always, or very commonly, a factor of fatigue, weakness, or difficulties with troublesome muscle spasms or muscle tone. Sometimes people will report difficulty with feeling their legs or feeling their extremities. And as a result of all those challenges, these patients have the difficulty with moving on a regular basis, exercising on a regular basis, and often also struggle with secondary impairments that come due to the chronic impairment. So I would say it requires a whole person approach, and it's very individualized, and it takes a person who's willing to sit down, listen, and address each concern in a way that leads to the ultimate goal of somebody repairing their relationship with mobility in a way that allows them to achieve the goals that are meaningful and important to them.
So as I mentioned, I focus a lot on voiding dysfunction, pelvic floor disorders. It's very common for people with these conditions to experience urinary issues. Now, majority that presents is I go too often or too urgently, I have trouble urinating, I may need catheters. One of the challenging things is what I subspecialize in is a minority in America, honestly, of urologists who focus on this. So I think, unfortunately, a lot of patients are just given catheters and told that's how they have to live their life. And while that may be true, there are opportunities to intervene. And I think people like myself who specialize understand how to figure out if there is an option to ideally improve urinary function without catheters, or maybe in conjunction with catheters, but in a way that's a little bit more manageable for the individual and their limitations. And you know, part of what often gets overlooked is sexual dysfunction. I think that's a very sensitive topic for any patient. And when patients present to their doctors with many issues, as you mentioned, fatigue and mobility issues, and there just seems like a much higher priority for the, some might say, more important aspects, but we undermine how important intimacy is in our lives and how much a role that plays on everything: fatigue, mood, sense of self, body image, etc. So I think there's a real opportunity, if you have access to specialized care, to just have that conversation and have the time and opportunity to discuss options, ways to improve. And it's not like people with these conditions get treatments that are outside the box. No, they just get the validated, proven therapies. They're just not often offered it unless they see the right person. So.
Yeah, so in my field, mainly is vision loss, double vision, and blurry vision. So for patients who have acute vision loss, we usually diagnose the patient where they have, we usually find out whether the patient has optic neuritis or other conditions going on. If the patient has acute optic neuritis, we start treatment immediately. And the other chronic conditions could be like double vision and nystagmus, eye uncontrolled shaking, and at least we use medication to help them. So if the patient's vision is very poor, and we usually refer them to the lighthouse, so they have further ways to help the patient.
So I think we all have experience with the healthcare system in the U.S. It's quite complex to navigate, even in one specialty. My sense is that many patients, once they have their relapses under control, they may not necessarily think to go to a physical therapist or a urologist or a neuro-ophthalmologist for specific eye issues. So I'm curious how NMOSD MOGAD patients find their way to you. Is it typically a referral from the neurologist, or is it only when they have very severe symptoms that they present to you? Just, I'm wondering your experience, how they come to you, and then what you would advise newly diagnosed patients to do, maybe be a little bit more proactive in potentially contacting your specialties.
From the view of physical therapy, usually I will see a patient after they're referred by any medical provider. Usually it's either a primary care provider or a neurologist. It could be for difficulty walking. It could be for, sometimes it's just, this person was diagnosed. Can we look into their lifestyle habits? Can we look into how can we make an exercise program that addresses their difficulties? Sometimes it's patients that we have been seeing that were diagnosed with MS and eventually receive a new diagnosis. So we really see all kind of different timelines in somebody's specific journey. I would say for somebody who's newly diagnosed, exercise is going to be a really key aspect of the management because it addresses so many of the symptoms that make their lives or changes the way that they live their lives in terms of their movement system. So if you're not exercising right now, and you're having difficulty starting to exercise, maybe going to somebody who has experience in creating a program for you could be easy. It can make this journey a little bit more accessible. If you feel you have the self-agency and autonomy to start, I would say start small, find something that's enjoyable, find something that brings you meaning and purpose in terms of your mobility, and move more and move often, is what I would say.
So I would probably estimate most of my patients do come from referrals from neurology. So I'm very lucky at the University of Miami to have such amazing colleagues, and clearly as evidenced by their partnership with the Smira Foundation, this really focus on improving patient outcomes, awareness, and targeting therapies. So the majority of my referrals probably do come from neurology. Now, I think it's also an advice I would give to every individual is, though you may have a title of a condition, you still have a problem that's common. So especially when it comes to the problems I treat, urinary issues, sexual dysfunction, pelvic pain, those sorts of things, you can find that just by going to your local urologist, your local urogynecologist, and ideally you can share with them, listen, I think I might have a more complex condition. Do you treat this? And you can even use the word neurourology, and then they'll know where to refer or hopefully help you get access. But I guess I would just encourage the individual, I think sometimes it's hard to not feel like only a neurologist can handle your conditions, but we can. And so, sometimes you put a lot of pressure on the patient, especially in a place like America, to figure these things out for yourselves, and I think that's tragic. But at the end of the day, it's an opportunity. You have a problem, don't be afraid to seek it out. And if a physician says it's too complex for me, say, that's okay, tell me where to go, though.
So for us neuro-ophthalmologists, patients with NMOSD and MOGAD, they usually come directly to us because they have vision problems. They cannot see clearly. Of course, we work closely with neurologists, neuroimmunologists, and we follow up their patients' vision problem also. Like what I said, we do the special tests for the eye to figure out the eye condition, whether these tests can also help to predict or monitor disease progression and therapeutic efficacy.
So you all work at a very prominent academic medical center or with referrals from these sorts of care facilities. Do you have experience working in an integrated care team model? Is there somehow a benefit to the patient, maybe proactively seeing all these relative specialists to manage their condition once they're diagnosed and treated for NMOSD and MOGAD? Any experience with that at University of Miami?
Personally, I spent some time working with a multidisciplinary ALS clinic. So that is a model where a patient has a vast amount of concerns and difficulties and symptoms, and it really requires a specialized and interdisciplinary management to really get the most out of their treatments. I know the university also has an MS clinic, which has a similar model where a patient might be able to see a variety of clinical specialties. So in the case of ALS, for example, just to draw a parallel, really multidisciplinary care is the gold standard to really address everything that comes with this condition. I would say in the patients that I see with similar conditions, at the very least, their providers being able to communicate in terms of how is a medication affecting their side effects with their mobility, let's say changes in symptoms and spasticity, changes in the way they walk, or improvements, being able to communicate and being able to be part, and everybody kind of add their expertise and draw from the time they spend with the patient to really make decisions that are important for their goals.
Sad to say, I'm not aware of a multidisciplinary program or institute that tries to do that with urologists. I think, even as we heard in the panel before, these are the kind of conversations we need to have about like what's missing and how are you not providing appropriate access to care. So the way we do it is kind of the old school way, where the neurologist asks the right questions, and knows the right person to send it to. And so again, UM's great in that they know that. I can't say that's true across the nation. And it's a good point that that's something we might need to start focusing on.
Yeah, we don't have this formal format of multiple discipline care, but we work very closely with neuroimmunologists, also with other subspecialties in our eye institute, like ocular plastics. And we kind of set up a fast pathway for patients to see our neuroimmunologist to start the proper long-term treatment once we diagnose the patient. And also, neuroimmunologists will send their patient back to us for eye problems, for recurred eye problems or new onset eye problems. So we have this very fast pathway between these two subspecialties. Of course, with our own within our own eye institute, we have very close connection with different other subspecialties.
So we have only 3 specialties here that address some of the symptoms that you all may live with NMOSD and MOGAD. There are other areas that we know are very important to patients, living with chronic pain, neurasthenic pain, living with sleeplessness, anxiety, mental health. We could have probably 10 people on this stage if we wanted to. But since we have 3 specialists here, I'd like to open it up to the audience. Any questions for these specialties? See a couple hands up.
Hey there. So, Dr. Syan, I deal with some recurrent UTIs. I do cranberries, I do Demonos, I do water. I try to not, have, everything. But I continue to have UTIs. I know that's kind of a common symptom of, maybe it's the medicine I'm on, maybe it's just state of things. I do have issues, my bladder not being able to release it all the way. I have done pelvic floor therapy, and that helped a lot, but I do still have UTIs maybe, 4 or 5 times a year, which is not great. Do you have any words of advice or anything beyond that kind of thing?
Yeah, so it's true that recurrent UTIs is common, but it's treatable. The key thing that you shared with me, thank you for sharing with the room, is that you're not emptying your bladder fully. So that might be the key component behind why you're getting the UTIs. So my best word of advice is come see someone like me, a neurourologist, who can just investigate what's going on. We have treatment options out there. And it's again, the thing I like to emphasize is they're not specific for people with, complex disorders. They're people without it have great success. So we're not doing experimental stuff. We're doing things that have proven benefit. So I think for you, it is a good idea to establish care and see what opportunities are out there to make your life easier. UTIs are the worst. So, you deserve to be seen and investigated.
Yeah, okay, thank you.
First of all, thank you all so much for coming. It's so important to hear from the other specialists that are involved in our care. But Dr. Raveen, I'm really happy that you're here because so many of us struggle with the issues that you address in your specialty, but we never want to ask it out loud or seek help because it's quote unquote embarrassing. But as a patient myself, I know that there are so many solutions to many of our challenges, and I would love if you could tell the patients and caregivers in the room maybe about some of the incontinence solutions, whether it's the oral medications or the Botox treatments that folks can get or the InterStem or anything that you want to share.
mean, you just named them all. Well done. Are you a neurourologist? So yeah, you're absolutely right. So the most common condition being going too often and urgently, there's pills. And pills can be highly effective. Some people it's as effective as in 80% of people, just pills alone, taking them daily. Now, pills have side effects, and sometimes they don't really meet people's goals. So then there's other things, procedures. There's, as Sumara mentioned, there's Botox injections. So just like we Botox the muscles of our face to relax the muscles of the face, we can Botox the bladder. The nice thing about that is we do it in clinic. It's incredibly low risk. You don't have to get anesthesia, nothing. There's the InterStim, which is sort of like a pacemaker for the heart, which is super effective for people with complex urinary issues, so especially those who are not emptying their bladder well. It actually stimulates the nerve. It acts on the nerves. And so it's been studied more and more increasingly among people with neurologic disease because previously they weren't MRI compatible. So we tended to avoid placing it in people with neurologic diseases because people need MRIs. Now that it's been compatible for like 7 years, maybe not 7 years, but a number of years, we've done studies in MS patients with back surgery, and it is 80% effective. It's super highly effective. It's no longer a barrier to patients. And then there's even simpler things, like it's almost like an acupuncture. It's use a little acupuncture needle in the ankle, and you can get stimulation therapy there, which can help with bladder dysfunction and other issues. So super well established treatment modalities that people with these conditions are candidates for. And then sometimes it's more complex. The reality is sometimes people have very complex bladders as a result of these diseases, but that's also where you see a neurourologist. And if we're talking about bigger surgery, we offer that. There's options. It's just, I think what's hard is people don't know where to go.
A question for physical therapy as a caregiver. Post-episodic physical therapy is huge for NMOSD patients. But many insurance companies have 15 sessions a year, 20 sessions a year, and sessions you need ongoing forever. So what has been your experience breaking through those limits that insurance companies put on you, knowing that your patient needs more, that the person you're giving care for needs more than 15 sessions, 20 sessions. They pretty much need a session forever. What's been your experience getting through those barriers?
I think creative problem solving in that case is very individualized, right? Like you're saying, some people might be able to see me even less than 15 times. Sometimes they can only see me 5 times. So that should be at the forefront of the partnership between the patient and the therapist. Every plan is different. In some cases, I see somebody 1 time a month, and then I will make sure that my interventions at the beginning are all centered around equipping a patient with the knowledge, or a caregiver with the knowledge, the ability to implement an exercise program that is safe, that is tailored to their needs and their goals. Sometimes I have the luxury of seeing somebody a lot more often, but the important part is with what we have, right? There is the barrier in terms of coverage and coverage of care. What can we do to be creative? What do I need to do from my side of things to make sure you feel safe and you feel like you can be successful at implementing some of these things at home? Sometimes it's not the best, but can we make the best of this scenario, and can we tackle some of the things that are important to you with what we have? So it takes a little bit of creativity and a little bit of thinking outside of the box, but it's definitely very, very feasible. I have patients that I have seen maybe for the entire year, and we spread their visits, their 15 visits over the year, and then we make sure little by little we progress the plan, and as things come up or as things get better, we're able to tailor it to their needs.
Any other questions from the audience? If not, I just want to mention that, in many cases, to access these sorts of specialists, you may in fact need a referral from neurologists. So in the spirit of self-advocacy, shared decision-making, you may have to nudge your neurologist to get a referral. And the earlier you can intervene on some of these symptoms and side effects and other challenges you face, often the better the outcome. So don't be shy. Advocate for yourself, and if you need to, push to see a specialist. And I'd like to thank my panelists for all their wisdom and for supporting NMOSD and MOGAD patients.
Thank you.